নাজাত একটু স্টপ করো, আমি একটু শেয়ার করি
স্ক্রিন শেয়ারিং অফ করো নাজাত।
Good evening. Welcome you all to our weekly virtual program. From this COVID era, we have been trying to keep everybody connected academically. So our regular series is how should I treat my patients following evidence-based medicine. Today, our topics is management of anal cancer. Our total local faculty is Lieutenant Colonel Dr. Nazat Sultana. She is a radiation oncologist from the Cancer Center of CMH. She has done her post-graduation and then took a fellowship training in TMH Mumbai, and now she is doing a wonderful job in CMH. Today she will be talking on the management of anal cancer. We have two overseas guest faculty, Dr. Zahid Khan, a known face who has graduated from Chittagong Medical College and working as a consultant medical oncologist, Clatterbridge Cancer Center, Liverpool, UK, and Dr. Tariq Abdullah, who is a consultant clinical oncologist in Bridgestone, west of Scotland Cancer Center, UK, who has graduated from Dhaka Medical College. So Zahid was reluctant because the role of medical oncologist is very minimum, but still we requested, and thanks Zahid for joining, and also thanks to Tariq for joining with us. So as per custom, we always start with few words from our president and our patron. So I would like to request our president, Dr. Rehman Haisar, to formally start the session, then we move to our session. Dr. Rehman Haisar.
Rahim. Thank you, Dr. Kamal. Today we have subject, a very important subject of cancer of anal canal. We have two jewels of Bangladesh who are residing in UK, Dr. Zahid Khan and Dr. Tariq Abdullah. Our presenter is a Pearl of Bangladesh, Dr. Nazat Sultana. So without any delay, let us start. Over to you, Kamal.
So I will like to request Dr. Nazat to start her presentation. Dr. Nazat.
Nazat, screen sharing দাও Nazat.
Screen share করো।
Screen share.
ফুল স্ক্রিন করো।
একসাথে যাও।
Is it okay?
না ফুল হ্যাঁ ওকে ঠিক আছে হ্যাঁ
স্টার্ট করো।
Respected teachers and learned audience, Assalamu alaikum. Thank you Oncology Club for arranging such a academic session and continuing it more than 1 year. Today's topic of discussion is management of anal cancer. All of you know about the anatomy and the lymphatic drainage of anal canal, but I want to highlight that because anal canal is a very small organ that is almost about 4 centimeter, but it has some peculiarities that it has two kinds of epithelium above the dentate line, that is a columnar, and the below the dentate line is squamous cell carcinoma. And lymphatic drainage is also important in lymph node involvement in inguinal is most common in the anal canal carcinoma, and we have to assess also the inguinal node involvement because target volume and the stage is also will be changed if lymph node is involved. Anal canal cancer is not very rare, but it is rare. In our center in last 3 years, only 6 cases were received a radiotherapy for anal canal carcinoma, Median age at diagnosis usually 62 years, and squamous cell carcinoma is the most common, more than 90%.
Dr.
The main
Raja,
culprit, sir,
sorry for interrupting. Are you changing the slide?
sir,
Only the first slide is visible. Another slides are not visible yet.
sir,
To the
sir,
program
I'm
slide.
changing. Yes, sir, I'm changing the slide, but it is not showing. Sorry, sir, let me check.
চেক আমি কোনো স্লাইডই দেখতে পাচ্ছি না।
ও স্লাইড চেঞ্জ হচ্ছে না, এখানে শো করতেছে না।
ইয়ে করে আমরা এক কাজ করি,
দেখতে পাচ্ছেন না।
আচ্ছা লেট মি প্লে।
সুমনের কাছে প্রেজেন্টেশন আছে না?
আচ্ছা আচ্ছা আমি দেখতেছি।
তুমি শেয়ার করো, নাজাত তুমি সুমন শেয়ার করো। বাট এটা কি ফাইনালটা তোমার কাছে নাই? তোমার তো আগেরটা আছে।
হ্যাঁ, ফাইনালটা নাই আসলে, আমি তো পাঠাইতে পারবো।
এরপরে কোন এডিট ছিল?
হ্যাঁ ছিল, চেঞ্জ ছিল।
ইমেল করে দাও।
কিন্তু তোমারটা তো চেঞ্জ হচ্ছিল, একটু আগে তো স্ক্রল করলাম আমরা তো দেখলাম।
স্টপ করে আবার শেয়ার করো, স্টপ করে আবার শেয়ার করো।
আবার স্টপ করে আবার স্ক্রিন শেয়ার করো তো। স্ক্রিন শেয়ারিংটা আবার করো, অফ করো এটা। আবার স্ক্রিন শেয়ার করো।
আবার স্ক্রিন শেয়ার দাও।
ভিডিও গুলো অফ করে দিলেই ভালো, সবার ভিডিও এক্সেপ্ট দি স্পিকার।
এটাও করতে পারি আমরা।
Can her slides be played from an admin, from a different person?
Right, আমি ট্রাই করতেছি।
সুমন, আমার মনে হয় ও মেইল করে দে। You can start from here and then later on.
এখান থেকে একটা মেইল করি তো।
মেইল করে দাও, সুমনকে মেইল করে দাও।
ঠিক আছে,
তুমি স্টপ করে তুমি আবার জয়েন করো, রিজয়েন করে আবার জয়েন করো।
কামর ভাই আমাকে স্ক্রিন শেয়ারিং অপশন দেন, আমি ওইটা প্লে করতেছি।
সবার এখন মাল্টিপল, ইউ ক্যান শেয়ার।
দেখা যাচ্ছে স্ক্রিন শেয়ার দেখা যাচ্ছে
না, নাজাতকে স্টপ করতে হবে, নাহলে তুমি
এটা তো আবার স্টার্ট করছে।
এটা কি সুমনের স্ক্রিন?
এটা আমার স্ক্রিন।
ওকে, নাজাত তুমি মেইল করে দাও।
হ্যাঁ ঠিক আছে,
নাজাত তুমি শুরু করো আর মেইলটা পাঠিয়ে দাও। নাজাত আমাকে শুনতে পাচ্ছ?
নাজাত কি আবার ডিসকানেক্ট হয়ে জয়েন করতেছে বোধহয়। ও কানেক্টেড নাই।
মোবাইল করো।
ও তো আছে, কানেক্টেড আছে তো। নাজাত তুমি তো আছো?
মোবাইল হিট করে রাখছে নাকি?
আমি পাঠাচ্ছি।
আমাকে পাঠাতে হবে না,
শেয়ার করছি, এটা তুমি বলা শুরু করো।
নাজাত তোমাকে পাঠাতে হবে না, যেটা আমি স্ক্রিন শেয়ার করতেছি তুমি এটাতেই বলো, অসুবিধা নেই। মাইনর এডিট এটা কোনো ইস্যু না। হ্যাঁ তুমি এটা দিয়ে শুরু করো, আমরা যেটা দিচ্ছি আমি এটাতে শুরু করো। হ্যাঁ দেখতে পাচ্ছ, স্ক্রিন দেখতে পাচ্ছ?
হ্যাঁ দেখতে পাচ্ছি।
বাস,
ওকে শুরু করো, একদম ফ্রম দ্য স্টার্ট শুরু করো। হ্যাঁ
একদম প্রথম থেকে আবার। ওকে,
হ্যাঁ শুরু করো।
ওকে। Respected teachers and learned audience, Assalamu alaikum. Thank you Oncology Club for arranging such kind of academic sessions and continuing it more than 1 year. Today's topic of discussion is management of anal cancer. I would like to discuss about the anatomy and the lymphatic drainage of anal canal. Anal canal is about 4 centimeter in length, and it is divided by the dentate line. There are two kinds of epithelium. Above the dentate line, there is columnar, and below the dentate line, that is squamous cell carcinoma. And nodal involvement is inguinal node involvement is most common. And during clinical assessment, also inguinal node palpation is very much important because it has changed the stage and also treatment decision. About the incidence, anal canal cancer is not very much rare, but it is rare. And almost 6 cases in last 3 years in our center we have diagnosed. And the median age of diagnosis is 62 years. And squamous cell carcinoma is the most common, and more than 90% of cancer is squamous cell carcinoma. HPV is the main culprit. Usually there is no symptoms, so many don't realize that they are infected. But HPV and P16 positivity associated with more favorable clinical response and increased survival as oropharyngeal carcinoma. These are the standard workup that includes the physical examination, including DRE and also inguinal node palpation, proctoscopy, FNSA if more than 1 cm of inguinal node size, MRI, pelvis, CT scan of thorax and abdomen. PET CT is optional. Gynecological assessment in women to exclude if there is any vaginal or vulvar intraepithelial neoplasia, and HIV test. This is the flow chart to show the the treatment of anal canal cancer, localized anal cancer. At first, you have to assess the tumor location and the epicenter. Then whether it is adenocarcinoma or squamous cell carcinoma. If adenocarcinoma, treatment is rectum, maybe in distal rectum or anal canal. And if it is squamous cell carcinoma, in that case, treatment of choice is concurrent chemoradiation. But if it is stage 1 anal margin tumor, that is wide local excision. And after wide local excision, if margin is adequate, then observation. If inadequate, re-excision is preferred. If re-excision is not possible, in that case, concurrent chemoradiation is the treatment of choice. Now, anal canal cancer treatment is evolved a journey from Negro to Plateau. Negro 1974, this is in a nutshell, the history of anal canal cancer treatment. From Negro, that is published in 1974, then Act 1 and RTOG 8704 1996, URTC 1997, RTOG 9811 in 2008, RTOG 9811 update in 2012, and Act 2 and RTOG 0529 in 2013. All 3 are randomized control trial phase 3. And now ongoing trial is Plateau, which incorporates the Act 3, 4, and 5. These are Norman Negro with his 2 colleagues. Actually, in 1974, just only the 3 cases, they presented in a gastro meeting that they have given a 30-day in 3 weeks with concurrent chemoradiation, and they have found that complete response. And after that, in 1981 with 19 cases, and in 1983 with 28 cases, same result was found. And at the time, concurrent chemoradiation was the standard of care. And surprisingly, after that, before 1970s, surgery is the option. But after that, till now, there is no randomized surgery with the concurrent chemoradiation in anal canal cancer treatment. And this is the Plateau. Plateau is personalizing the anal cancer radiotherapy dose. Incorporates Act 345. I will discuss later on. Now, in Act 199, which published in 1996, there are 2 arms. Radiotherapy and radiotherapy with 5-FU and mitomycin, which showed that there is a colostomy-free survival. Concurrent chemoradiation improves the colostomy-free survival and also local failure. Then RTOG 8704, which published in 1996, they have this thought that why mitomycin C is necessary. We can omit mitomycin C. 5-FU it is common in both all GI. But they have found the same result, concurrent chemoradiation with mitomycin C, higher colostomy-free survival and the disease-free survival. At URTC 1997, they have also found the same results. Now in 2008, RTOG 9811, they have compared 2-arm radiotherapy with the concurrent chemoradiation is 5-FU and mitomycin C. Another is a 5-FU with cisplatin. Because in squamous cell carcinoma, all of you know that squamous cell carcinoma cisplatin is very effective, but cisplatin failed to improve the disease-free survival and also worse colostomy rate. And there is an update of RTOG 9811, which published in 2012, that has also found that 5-FU mitomycin is better than the 5-FU cisplatin. And Act 1 update, which is published in 2010, the result is same. Now, Accord 3, which is published in 2012, it deals with is there any role of induction chemotherapy in management of anal canal cancer? And Act 2, which published in 2013 and incorporates more than 900 of patients, they deals with is there any role of maintenance chemotherapy after the concurrent chemoradiation? And the result is there is no role of induction chemotherapy. Also, there is no role of maintenance chemotherapy. This is the plateau which incorporates Act 3, 4, 5. It is easy to memorize. Act 5 is deals with the dose escalation, and Act 4 is deals with the dose de-escalation, and benchmark of radiotherapy dose is 50 gray. These all are ongoing. And Act 3 is a small group of patients only for T1 and 0. Then after excision, if margin less than 1 mm, radiotherapy dose is 41. There, another group is observation. All the primary endpoint is local regional failure. So above all 6 randomized trial, we have concluded that standard of care of is chemoradiation with FABIFO and mitomycin. And radiotherapy is the integral part. Now, radiotherapy plan. What are the, at first we have some prerequisite to for radiotherapy. That is the clinical examination, which includes the DRE and also the inguinal node palpation and parvaginal examination to assess any transmural vaginal involvement or anorectal vaginal fistula. And radiological imaging, that is MRI pelvis, and also more MRI pelvis is more accurate, and CT scan of abdomen, pelvis, and chest for staging purpose. Now, radiotherapy plan. What is our treatment aim of radiotherapy? That is optimal coverage of target volume and to reduce the rose to the organ at risk. And target volume includes, that is the gross primary and also gross node, and regional node, that is elective node, the pelvic and the inguinal lymph nodes. In RDOG 9811, there is a shrinkage fill technique and they have 3 phases of treatment. In phase 1, all are APPA fill. Upper border in AP fill, that is the lumbar 5, sector 1, and the inferior border is 2.5 cm around the anus. And lateral border is lateral inguinal, includes the lateral inguinal node. And in PF fill, superior border is above the sacroiliac joint and inferior border is 3 cm below the tumor or below the anal bulge, but lateral border is tip of the femoral head. So in PF fill, there is no coverage of the inguinal node. After phase 1, that is after 30.6 gray, there is a shrinkage of upper border filled by superior shrinkage of superior border, which reduced to the bottom of sacroiliac joints. And if there is no inguinal lymph node, there is a more shrinkage can be done in the epifill to avoid the inguinal node coverage. And in phase 3, there is a boost, which is used for the boost only gross node and the gross tumor. And so in phase 1, there is 30.6 to 36 in 70 to 20 fractions. In phase 2, 9 to 14 gray in 5 to 8 fractions. And in phase 3, 10 to 14 gray in 5 to 7 fractions. So total dose is 55 to 59 gray. Now, Act 2 is much simpler than the RTOG 9811. It has only 2 phases of treatment. And in first phase, there is 30.6 in 17 fractions. And superior border is 2 cm above the inferior aspect of sacroiliac joint, or 3 cm above the superior extent of the joint, whichever is superior. And inferior border is 3 cm below the anal margin, or 3 cm below the inferior most extent of the disease, whichever is inferior. And lateral border is same, lateral to the femoral head. In phase 2, dose was 19.8 in 11 fractions, and there is only boost to the gross primary and the gross node. If node is negative, only we have to take the boost to the primary, and it encompasses 3 cm around the GTV. Now, what about the late toxicity? It has been found that after concurrent chemoradiation, late toxicity grade 3 is grade 3 and above is up to 33.3%, and most commonly reported toxicities are fecal incontinence, diarrhea, and the ulceration. So IMRT appears to reduce the toxicity. So why the need for IMRT? To optimize the toxicity and to adequate target coverage. In RTOG 0529, which deals with the IMRT, and the patient was T2 to T4 and N0 to N3 non-metastatic. A primary endpoint was to reduce the grade 2 and GI and GU genitourinary toxicity. Secondary endpoint is to reduction of all adverse event. In RTOG 0529, okay, target volume is okay, gross tumor and the gross node. And CTV was GTP with 2.5 centimeter margin for the gross primary, and the for node that is 1 centimeter expansion, and elective node which covers the pelvic and the inguinal node. Here I'm showing the coverage CTV, that is 2.5 centimeter margin around the GTP, and the crop from natural barrier, that is issue-rectal fossa, muscle, and the bones. This is the pelvic node, which also the CTV is 1 centimeter from the GTP node and edited from the anatomical barrier. Is the inguinal node that extend from external iliac continue as a femoral basis, and lower border is the saphenofemoral junction. CTB elective node also covers the CTB mesorectum along with the CTB node. And the dose prescription in arteriosclerosis 0529 is 42N0, elective node is 42 gray in 28 fractions, and for primary is 50 gray in 28 fractions. And for T3, T4 tumor and N0 to N3, elective node is 45 gray in 30 fractions, and PTB primary 54 gray in 30 fractions. And for PTB node, it gross node size is more than 3 centimeter. In that case, 54 gray in 30 fraction. And if less than 3 centimeter, is 50.4 gray in 30 fractions. So the basic difference between the arteriosclerosis 9811 and arteriosclerosis 0529 is that in arteriosclerosis 0529, there is a no low risk volume. And so the whole region received the same dose as CTV high risk. Now, there was a gap in Act 2 at URTC 22861 because due to severe toxicity, and the treatment of anal cancer is really challenging both for the physician and also for the patient. So they have given, there is a 6-week plan gap in Act 1 before the boost, but it has been found that if there is a gap, total treatment time is increased and all local regional failure and the colostomy failure is much high. So there is no treatment plan, no planned gap in arteriosclerosis 9811 and arteriosclerosis 0529. In concurrent chemoradiation, we are using 5-FU and the mitomycin C, and these all are phase 2 trial, which has been shown that capacitabine can easily substitute of mitomycin C. Now, what is the time to assess the complete response? Complete clinical response in Act 2 data after concurrent chemoradiation has been found that complete clinical response 64% in 11 weeks, 80% in 18 weeks, and 85% in 26 weeks. So it can take 6 months for tumor to completely regress. So anal canal regress slowly concurrent chemoradiation. So optimum time point to assess the response is 26 weeks after the concurrent chemoradiation. DRE and palpation of inguinal node is the mainstay to assess the response. Anoscopy or proctoscopy is an additional option, but sometimes poorly tolerated and too much painful following concurrent chemoradiation. And 6-monthly MRI for 3 years, and suspicious progressive lesion should be biopsied. After concurrent radiation, what is this site of relapse? In Act 2, after concurrent chemoradiation of 50.4 gray, it has been found that maximum failure is pelvic failure, that is about 78% of total relapse. So carcinoma of anal canal usually localized with low risk of metastasis at presentation. Metastasis rare unless primary is uncontrolled. So local control is more important than the distant metastasis. Majority 70 to 90% respond to concurrent chemoradiation, but clinical T3, T4 disease is less favorable. Now, treatment of recurrent and metastatic disease. Recurrent may be local recurrence or the inguinal node recurrence. The treatment is surgery. If local recurrence, that is the APR, then we can keep the patient for surveillance. And if it is inguinal node recurrence, we can go for the groin dissection. And if patient doesn't receive any radiotherapy before, we can go for concurrent chemoradiation. And if patient receive radiotherapy, we can go for chemotherapy, peglycarbo. And if it's metastatic disease, we can give treatment option is chemotherapy, and first line is peglycarbo, or then FOLFOX, 5-FU, cisplatin, or modified DCF. This is a category 2B recommendation. Now, indirect trial, it is anal cancer metastatic trial, which compares the chemotherapy drugs between the cisplatin 5-FU and the carboplatin paclitaxel. And it has been found that objective response rate is about 59% in paclitaxel arm, and in cisplatin 5-FU arm is 57%. And overall survival is often paclitaxel in about 20 months and cisplatin 5-FU is 12 months. And progression-free survival in paclitaxel carboplatin 8 months and cisplatin 5-FU 5.7 months. So, yes. So in a nutshell, we can summarize that digital, anorectal, and the vaginal examination with inguinal node is an essential clinical tool. Female patient with anal intraepithelial neoplasia should be screened for the CIN and the VIN. Radiotherapy with concurrent 5-FU mitomycin is a standard of care for patients with localized squamous cell carcinoma. High resolution T2 MRI is needed for optimal assessment of the primary tumor. Capecitabine can be used as an alternative to 5-FU in combination with mitomycin C. There is no role of neoadjuvant and adjuvant chemotherapy. IMRT, BMAT, or 3D CRT are the recommended radiotherapy technique. Radiotherapy doses for T1 to T2 N0 lesion is more than 45 to 50 gray, 50.4 gray, and for T3, T4, and N1 lesion more than 50.4 gray or higher without planned gap. Optimal time point to assess the tumor response after concurrent chemoradiation is 26 weeks. Salvage surgery is considered for local residue or recurrent disease after concurrent chemoradiation. Paclitaxel should be considered for advanced anal cancer. And PD-1 or PD-L1 inhibitor may be considered to have progressed in first-line therapy. Thank you. Thank you very much.
Thank you, Nazat. We are sorry for the technical difficulties at the beginning, but I think you have made a very nice presentation. Now I would like to request Dr. Tariq to make some comment. Nazat, you can stop the screen share. Shuman, screen share. Okay.
No, it's a really nice presentation from Nazat, and the anal cancer is the main treatment is a radiotherapy. We all know that, and the paradigm has shifted from late 80s, and which Nazat very nicely mentioned. So about the historical events like the Robert De Nigro, who is a clinical oncologist, and I think is in Chicago, and so he treated few patients with a 5 centimeter or less size tumor, and then he published this paper, and then from 1980 to 1990, most of the patients actually getting radiotherapy as a primary treatment as opposed to APR. But since then, very little has changed, and it's very good to see that how Nazat presented 1980s, 1990s, and 2000, and what we are standing now. So the major thing actually in anal cancer where the change happened is from firstly the shift from surgery to radiotherapy, which is in late 80s, late 70s, and so late 80s and 90s and early 90s. And second thing is whether chemoradiotherapy, whether addition of chemotherapy does any benefit. The second and the third one was whether neoadjuvant or maintenance treatment does any benefit. And finally, the IMRT. And but if you look at these last 40 years, very little has changed. The same dose, almost the same regime for radiotherapy and also the chemotherapy we are using, what was used by Robert De Nigro in 1970s. So, and if you look at the recurrences and also the rate of failure, which has changed, but not dramatically. So there must be something something we need to think about actually why this is happening. And that's why this Plato trial actually came, because Robert De Nigro treated a very early stage tumor with a very small dose of radiotherapy. I think he treated with 30 gray only. And now all the patients we are treating even very high dose, like 50 gray or so. So basically the Plato trial is like dose escalation for high risk cancer, like node positive T3 and T4, and de-escalation for those who has low risk cancer, which is basically less than 4 centimeter, what they're saying. So that's the philosophy behind the Plato trial. I'm actually the principal investigator for the Plato trial for West of Scotland. And so I recruited a few patients for Act 5. I recruited very small number for Act 3 and Act 4. But Act 5 is the major one. We are looking into whether dose escalation does any benefit. So we'll talk about that later. But the few things actually came here about the investigation, like EUA. Proctoscopy. So proctoscopy, we do that, but for anal cancer, the main investigation is EUA. I'm not sure whether you do that there. That gives some more accurate information. And during the EUA, the surgeon perform vaginal examination to see vaginal involvement. And if there is a vaginal involvement, either in the MRI or in the UA, there is a worth considering defunction stoma. And so this is another thing. And I think there is about neoadjuvant chemotherapy is mentioned that there is no benefit. Yes, the multiple trial like URTC, RTOG, and ACCORD-3 didn't show any neoadjuvant benefit of neoadjuvant treatment. But yes, still some patients we are treating with neoadjuvant chemotherapy, and just because the disease is too big and is not encompassable within the radiotherapy field. And some of the patients actually will be cured in this method. And also all this neoadjuvant trial, they use cisplatin in the 5-year FIU. And we know that from Interact-2 trial, there is a phase 2, that now it is carboplatin Taxol is superior. So whether a new trial should be done with a carbotaxol, I'm not sure there's much interest among oncologists on that. We are generally believe the neoadjuvant is not helpful, but unless a small number of exceptional cases. To be honest, I think it's a really good presentation, covered thoroughly, and anal cancer is a rare type of cancer, and also it is, as I told, there's not much progress actually happened for a long time, but Plato probably will change in the future treatment and management options. And lastly, the IMRT, since IMRT came, there was a paper published in the Red Journal, which is, again, main author is actually, I think it's David Sebag Montefiore, who is the chief investigator for the Plato trial. He's based in Leeds. He's the person who actually did the MRC CR07, the short course radiotherapy trial, and also he's done the Aristotle trial for the rectal. He's a very renowned person. So he published the 5 centers data from IMRT, because there was always a fear that if we move from conventional to IMRT, is there any geographical miss? Like IMRT, we are doing like a very accurately, we are trying to volume the lymph node, the electives and everything, and the primary. And there is a risk of geographical miss. Previously, what you used to do like a conventional, we just like a pelvic break, we are treating like the whole pelvis. So since we moved to IMRT, there was always a bit fear, but this 5 centers is an observational study actually showed that 2 things. One is geographic. There's no geographical miss, and the second thing is toxicities are comparable, IMRT versus 2-phase conventional treatment. So that's all I will say now, but I'm happy to discuss further from the Plato perspective about how the patients are doing and everything, because I'm quite closely involved as a PI. Thank you.
Thank you, Tariq. Zahid, coming to you at a later time, because you are called at the metastatic setup.
Yes.
Because we're not going to believe for the new adjuvant. So Tariq, I'm moving to my, I have tried to prepare a few points that want to share up. So, I mean, first of all, I want to again congratulate Nazat, because today I have rediscovered her. I knew her from her pre-post-graduation era. I was fortunate to see her progress, growing up. But today I was impressed to see your wonderful presentation. Get ready for your next presentation, because you are going to get some assignment very soon. Sometimes it is not wise to do very good performance. So today you made a mistake, made a wonderful performance. So hopefully we are going to invite you for a new presentation very soon. So, I mean, anal cancer, as was said, it is not a very common one, but in your lifetime as a clinical oncologist, traditional, you are going to get few. And once you get one, you will have to face it. So what is interesting that you see the HPV is culprit for both anal and cervical cancer. But globally, when we see that there is a fall of cervical cancer by 2% per year, anal cancer is increasing 2.1% per year. So that was the CA data comprising from 2009 to 2018. And the survival, if you look at that, when it is localized, there is a very good survival, but in the metastatic, the survival is not very good, but the localized only on 48%. And again, if you look at the systemic review, that the survival is increasing from with time, that once it was 64%, then it came up to around 75%, comparing from 1980 to 2010. So with time, maybe we are doing some good, so survival is increasing. And as I was telling regarding the HPV, another alarming point is when the global HPV burden is 4.8% for cancer, but in India and sub-Saharan country, it is 14 to 15%. So this is another concern, but unfortunately, the vaccine that is effective for cervical cancer is not yet proved to be very good for anal cancer. Interesting thing that I digged out that 27, this was a French paper, they have seen the reason of delay in diagnosis of anal cancer. They found that 27% of the patient was thinking that they were having a hemorrhoids. They have taken some questionnaire and they have published an interesting paper. And they have some, in the this guideline, they have said that endoscopic and radiological evaluation should be done, performed to help determine staging and concomitant of metastatic. So that was the recommendation, because they were recommending that colonoscopy should be done, and 15% instead of colorectal neoplasm discovered at the time of diagnosis. But ESMO is telling colonoscopy is not required to assess pathology in the proximal bowel. So here I stop and ask Dr. Tariq. He said already UA is a thing and proctoscopy. So do you do colonoscopy in routine in anal cancer, Dr. Tariq?
No, we do not do routine colonoscopy in anal cancer, but we do EUA, and there's the main investigation, and we do sigmoidoscopy. But yes, few of my surgeons are still doing colonoscopy when they're doing sigmoidoscopy.
So you are doing the sigmoidoscopy?
We're doing sigmoidoscopy, and that is during the UA.
Okay.
So UA is the main investigation, and during the UA they do the sigmoidoscopy.
So do you do is there any message that you want to give that during anal carcinoma we need to look for something else in, up to the sigmoid, that there may be some concomitant disease, or why we are doing this? To see the extension or for anything else?
It's just to see the extension if it's a large tumor, but it is not mandatory. What is mandatory is the UA. And but some places, I know, I'm not sure in the Bangladesh you do routinely UA, but UA is the main investigation, diagnostic.
UA is done both cervical cancer, but I am not sure. I have never done it, but it is a new learning for me. But this was the why I said that there are some conflict of guidelines. The American Society of Colon and Rectal Surgeons, they said they should do it, but ESMO said don't do it. So I wanted to know from you, because we are fortunate that we are having a PI of Plateau with us. So why not to take the chance of sharing your experience? Okay,
sure. No, colonoscopy is not routinely required.
Okay, thank you. So in the treatment, what Nazat said, there are 6 phase 3 RCT and 1 phase 2 trial, and all have recommended that all these guidelines say that chemoradiotherapy is the gold standard. And unfortunately or fortunately, since 1974, what Dr. Tariq was telling, nothing much changed about the principle. Maybe some dose of some drugs has changed, but the principle is still the same. And now what is recommended that we should give radiotherapy, it should be around more than 50 gray. 5-FU mitomycin is concurrent, is still the gold standard, and many effort has proved that mitomycin is superior. And as Nazat said, Accord 3 have shown no added benefit of induction or boost. And cisplatin is not a good player here compared to mitomycin. But the problem is, even we are looking at chemoradiotherapy, we don't know what is the dose for which the Plato is designed, what Dr. Tariq was telling. So we are waiting for the plateau trial. But at this moment, Dr. Tariq, what is your recommendation for the dose? What you practice or what you suggest unless we get the plateau trial result?
Yeah. So there is 3 dose level, and one for the elective to the pelvic lymph node, which is uninvolved pelvic lymph node and inguinal node. We treat 40 gray in 28 fraction. And for early stage tumor, the primary get 50.4 gray. So early stage we defined, which is T1, T2, and N naught. For advanced stage, advanced stage we define as T3, T4, N, NE. So basically T3, T4, N naught, or T1, T2, N1. And we know that anal cancer staging and the TNM8 has changed. Now there is no N1, 2, 3. It is N1A, 1B, and 1C. And however, in the Plato, they're still using TNM7. So basically what I'm saying, the dose 53.4 gray for advanced stage, and that is to the primary. And for early stage, 50.4 gray to the primary, and elective always gets 40 gray. And all are on 28 fraction. And but those who are node positive, though the primary getting, because it's advanced stage, we are considering, and they are getting 53.2 gray. 53.2 gray, the primary is getting, and their lymph node is getting 50.4 gray, unless lymph node is above 3 centimeter. Those above 3 centimeter lymph node gets 53.2. So basically 53.2, 50.4, and 40 gray, there's 3 dose level. Primary higher stage gets 53.2, primary low early stage gets 50.4, elective getting 40 gray. And lymph nodes, if it's involved, generally 50 gray.
Thank you, Tariq. So the point that already you brought into the discussion, that whether it's 3D or IMRT. So in many of the papers, we know IMRT is a good player for toxicity. But in this paper, they have published this from USA, that they have shown that not only toxicity, there is a fair difference of survival by using of IMRT. So the next question to you is, when we are using IMRT, we are doing SIB, and where we're not using IMRT, we are going sequential. So, I mean, what is your take? SIB or sequential, or no problem, we can take anyone.
So 3D conventional for anal cancer has become obsolete now. So is all the centers in the UK actually moved to IMRT? And I think in Bangladesh, lots of patients getting IMRT, there shouldn't be any problem. But 3D conventional, but Nazat has shown the box failed, like top border, bottom border, inferior and superior, and anterior and posterior. So those we used to do before 2012, I think. After 2012, we moved to IMRT, all the patients. So therefore, we have only one option here in the UK, which is simultaneous integrated boost. If you showed, and Nazat also showed ACCORD 3, which mentioned that boost doesn't do any benefit, but ACCORD 3, they use the conventional 3D conventional treatment, and their total treatment time was more. And so now in Plato or in IMRT, we have got this opportunity to do SIB. So the answer to your question is yes, SIB with IMRT is the only treatment option now in the UK. We don't do.
So, I mean, do you want to give a comment to this, that if we are doing this 3D, we should not chase the dose very higher, like in the boost and other things? Should be very conservative, because still we don't know very high doses being much good. But if it is IMRT, we can go. I mean, sequential boost is not preferred, but if I'm doing SIB, then I can chase the dose some higher.
In the conventional, the dose we go maximum up to 50.4 gray. In the primary, and the pelvis getting I think 30 gray. 30.6 gray or something. So you can see that elective dose is actually lower than what we normally use in conventional. The primary dose is also, we don't go up to 53.2. We go up to 50.4 in primary and conventional. In the booster, yes, I mean, you can always add at the end. That you're trying to say, isn't it? Whether we will add the sequential boost at the end. So that will increase the total length of the treatment, and which is for squamous cell cancer per se, which is we don't suggest. So that's why conventional is not an answer here.
So, I mean, what I understand, Tariq, that in a conventional, we have two limitations. I mean, there is a toxicity, and even we wish to paint a dose to different areas, we cannot do, we have some limitation. So even I wish to segregate a dose to different part, sometimes unintentionally somewhere I give underdose, somewhere I'm giving overdose, because I cannot really control the dose like IMRT. So that's why, I mean, anal canal is one of the area like nasopharynx that IMRT is the treatment. I mean, we cannot, I mean, today we cannot think of a 3D for nasopharynx, but once upon a time when there was no IMRT, people treated 3D. So that is how things evolve. And probably we say that sometimes we make a joke that IMRT was designed for prostate and nasopharynx and also maybe for anal canal. So the message is that, I mean, this is such a complex planning of three different dose areas. So IMRT is the preferred modality for treating this patient. Okay, so now I move to the next issue is the response of the treatment. Personally, I can tell you that once I treated a patient of anal cancer. He was a senior citizen of the country, well respected, and he had a severe pain. And at the end of the treatment, some of my colleagues was ready to do a biopsy, open it up. Somebody was chasing to a surgery. I mean, what not? I was begging them not to do anything. Finally, thank God, nothing happened. One of the Singaporean colorectal surgeon, incidentally visited Bangladesh and saw the patient, said it is nothing, it is the radiation reaction. So there we could save the patient. So, I mean, this message reminded me that, I mean, very horrifying experience that I had a few years back. So what is recommended? Biopsies of persistent clinically suspicious lesion 8 to 12 weeks after CRT completion are not routinely recommended in anal cancer. Lack of clinical response in 3 months is not conclusive for salvage surgery. Reassessment at 6 months often shows late but clinically significant regression. And this paper published in British Journal of Radiology, and they say the majority of the tumor that persists recur typically do so within first 24 months following complete CRT. And this Act 2 paper, a post hoc analysis of Act 2 have shown that optimum time to assess is at 26 weeks. So like rectal cancer, I mean, in rectal cancer, well, there is no harm because maybe we are doing an early surgery, we are losing the chance of sphincter preservation. But here, maybe we land is a big issue. I mean, prematurely, if we land to a surgery, maybe it can create a big havoc. Any comment on this? Yeah, Tariq, assessment time.
The assessment time we used to do at 3 months, 3 months MRI and clinical examination after radiotherapy. Now we are doing all in 6 months. We're doing 3 months, but if at 3 months, if there is residual disease, we do not go for the biopsy straight or not an EUA. So we do another MRI scan, another examination at 6 months. So that is a routine practice. And after 6 months, if there is a persistent disease, then the patient is discussed for salvage surgery that we are doing.
So that is the message, Tariq, I wanted to share to you, that in anal cancer, if somebody is treating whatever the dose, whatever the thing, you have treated somebody, you need to be, I mean, judicious to hand over the patient for salvage surgery. Take time at least up to 6 months to declare that the patient needs a salvage surgery, because we have seen in papers that they're even 24 months, I mean, they are getting some result long term. So optimum is 26 weeks, that is, 6 months. So
Yes, and Pawan bhai, just want to comment about that patient about rectal pain just after treatment. So that is few months after the treatment the patient had this.
no, it started during the radiotherapy, and the end of the radiotherapy it was gradually increasing. That is the point I'm coming. So this is a new learning also. I listen, I learn. So I am coming to you on that issue also.
Okay.
So pre-radiotherapy, chemoradiotherapy, colostomy. Approximately 10 to 20% of patients with anal cancer will require a pre-treatment colostomy. Indication is said that anorectal pain, fecal incontinence, or anticipated fecal incontinence during chemoradiotherapy. ESMO guidelines said that ESMO guideline I took out because I think PL, just last month they have published it. I mean, it is just in the proof setup, not yet totally published. So I think one of the recent one is the ESMO. They have said pre-CRT colostomy should be considered patient with locally advanced anal cancer with or anticipated anorectal pain or fecal incontinence and rectovaginal fistula. Patient should be advised of the likelihood that their colostomy will be maybe permanent. I mean, their colostomy will be permanent. So this is something that I want to bring up, Tarek, that we know this is a very sensitive area when we are giving chemoradiotherapy. If they are passing the stool, it will be painful. And at the end of the radiation, the total life becomes painful. So what is your practice? How you manage it? Do you go for a diversion or how you do?
We do almost the same. Basically, if in three situations we do defunction colostomy. So if there is involvement in the vagina, and also we ask how much the involvement in the vagina. If it's just an outer wall, probably okay. But if it's like in through and through, then we definitely would suggest. And that the reason is because during the treatment, when the patient gets response, it just causes a fistula, and we do not want someone to have surgery or the stoma formation during the radiotherapy treatment, because that will increase the total length of treatment. So one is vaginal involvement. Second is obstructive symptom. If the patient getting large tumor and the cannot pass any stool. And the third thing is if it is a severe pain, and so patient is unable to pass stool. So there's a three situation we do, but that needs to be discussed with the patient, because generally it is said that 50% of the patient, the colostomy cannot be reversed because of the damage to the bowel due to radiation. So it needs to be clearly explained to the patient, because the reason we are doing chemoradiotherapy is to preserve the organ, to preserve the sphincter. So yes, by giving defunction colostomy and chemoradiotherapy, we are preserving the sphincter, but we are still ending 50% of the patient actually end up with a stoma. So that needs to be explained to the patient.
Can you please explain here? I'm not very clear, Tarek, that we are making a defunction colostomy, and then end of the treatment, what is the harm of reversal?
We do not do reversal. In my practice, I do not do reversal for a certain time, because there is a risk of recurrence. If I do reversal and then patient get a recurrence, go surgery, so just another unnecessary surgery needs to be done. So that's why I wait longer. And we know that generally after 3 years, as ESMO says, that 99% of the patients' cancer doesn't come back. I mean, they haven't said 100% because nothing in life is 100%. So they just quoted 99%. After 2 years, significant number of the patient doesn't get any recurrence. So generally, I wait for 2 years. But it is if the patient thinks that quality of life is severely affected with the defunction bag and everything. So yes, the patient can always have that. But as an oncologist, I would suggest to wait at least 2 years.
Thank you, Tarek. So now I want to hear from you. There is one question from a student that what is dose painting? I would like you to mention, because it will be good for you to bring up the dose painting, because you have been talking about the IMRT and the anal cancer. It's a wonderful area to explain this also. And I will ask you to give us some lights on the plateau that you are working, some few minutes on the plateau. So then I will move to Zahid.
Okay.
Yes, Tarek.
So yeah, so dose painting, basically in IMRT, we can use different type of doses, and we know that as a radiation oncologist, we all know that how IMRT works. works. So I'm not going through that detail. So basically in anal cancer, what we used to do pre-IMRT time was use the two-phase conventional 3D radiotherapy planning. So which Nazat already shown. So in the first phase getting 30.6 gray and second phase getting the rest of the 50.4 gray, altogether 28 fraction. But those were not a dose painting. Those are patient getting straight radiotherapy on the phase 1 and phase 2 with the same dose of the whole pelvis. So when you move to IMRT, so we can actually choose the dose, actually what dose each organ will be getting, and that is basically dose painting. So this is true for IMRT everywhere, including head and neck and other critical places. So I think it'll be easier if I can show you in the screen what it is. In terms of the Plato, yes, we opened that in nearly 3 years ago in our center, and when we started Plato, there are many things happening in my center, and we have to change. Our anal cancer treatment was was done in different centers. Like in the UK, it probably works slightly differently. Like we have under a tertiary, like an oncology center, there are a few local hospitals where the patients are seen. So basically, in the west of Scotland, we have one cancer center, but we go and do the clinics in different places. And so basically, anal cancer were treated in different places before. And since we opened the Plato, we actually centralized the service. So we are referring all the anal cancer to one clinic, and which actually I started in 2018 single-handedly. Then another 2 consultants joined. And that the whole thing was done for the purpose of opening Plato, so that we can actually treat more effectively. So there was always a bit of fear, because if we treat a very high dose in the Act 5 trial, how the patient will respond, particularly the older elderly patient, and also in the younger patient with long-term toxicities, because we know that anal cancer has got a bimodal distribution, so very young age gets some disease, and also the old. Interestingly, there was, I think it's 1.5 years ago, all the PIs were called in Leeds, and they presented first 70 patients who in the Act 5 trial. We know that in Act 5, there's a standard arm getting 53.4 gray, and there is a first dose escalation arm, they're getting 58.8 gray, and second dose escalation, they're getting 61.6, I think. So there's I would be slightly worried giving such a high dose, like 58 or 61, someone in the pelvis. But reassuringly, they told the first 70 patient, the acute toxicity and early late toxicity actually comparable, and is not any different, particularly in elderly group as well. So that gave some amount of reassurance, but we don't know about the late toxicities. In Plato, there are some difficulty, because it is the boost they're using is not only to the primary, they're also using that high dose boost to the involved lymph node. So it means if someone got the inguinal lymph node or presectal lymph node or external or interiliac lymph node, all are getting this 61.6 gray in the dose escalation arm. So, and by this time you join this together, and you know that in IMRT, even there is a bit gap from lymph node to the primary, but when you actually do this radiotherapy planning, that gap probably getting increased amount of radiation as well. So because they cannot avoid that. So so total pelvis is getting really high dose. So that could be sometimes worrying. I've got few patients who I wanted to start treatment on the Plato. By this time, patient progresses so soon, so I have to give some chemotherapy first. And we know there is no role for induction chemotherapy, but we try this as a palliative intent and a very good response, then we go for consolidation radiotherapy. So, and we did that and treated many patients. So that's about Act 5. And for Act 4, a dose de-escalation arm, and because we know that Robert De Negro, when he used this 30 grain 15 fraction in 1970s and 80s, he treated, I think it's a first 104 patient, he found at least 90% of the patient a complete clinical response. And so we know that some patient, they don't need such a high dose like 50.4 gray. So, and that's why this early stage patient, like less than 4 centimeter tumor, they are treating 41.4 grain 23 fraction with chemotherapy, and the other arm is the standard arm. And again, I had one patient I treated with a lower dose, and she had a complete response, and her tumor size was 3.8 centimeter. So my other colleagues actually was nervous and saying, okay, no, we probably treat that with 50.4, shouldn't be on the Act 4 trial. So I was brave enough to treat, and the patient had a complete response. And she was elderly, so it is very good for her. She avoid toxicities. Act 3 is basically is a non-randomized trial where only for the anal margin, after resection, if the margin is 1 millimeter or less, then they get radiotherapy, which is 41.4 gray in the trial. And and other arm is observation. So mainly Act 4 and Act 5 has got probably more significance for the changing of treatment in the future. So yeah, that's all about Plato from my experience, but I was happy to answer any specific questions about Plato. Thank you.
Thank you, Tariq. I have one specific question. Just now I'm treating the patient. The patient was diagnosed having a anal fistula. Finally, biopsy proved that it was an anal cancer. So it was a non-healing fistula. So, you know, we don't love non-healing area sometimes to treat, especially this area. We don't like the skin to be breached. But in this type of situation, we know that we wait, it will never heal. So if we treat, we are taking a risk because, you know, this is an open area. So do you have any tips for this type of situation?
So the patient hasn't had any chemoradiotherapy yet?
No, we have started. The patient is going on treatment. I mean, the patient is now taking treatment. I had no other option. I had to start because I could not wait. I realized that it is not going to heal because finally it was a malignant ulcer. It is not a infected ulcer. So it was a recurrent ulcer, and finally it ended up to be a anal cancer, and I have confirmed that it was a squamous, and I wanted to treat her with CTRT, but I was scared because it is a raw area and I'm going to start treatment. Am I anticipating any problem? That was my question.
Yeah, and is a fistula from the anal canal to the skin?
Yes.
Okay. No, I think we do the same thing here, and we'll treat the patient and would see how what response the patient is getting. So still there's a chance of complete response. What we say generally about 80%, 90%, depends on the stage and stage of the tumor. And so following the chemoradiotherapy, we would assess and whether fistula is still there, and whether patient gets some fibrosis, fistula is closing with the fibrosis. And if not, then we'll speak to the surgeon if flap can be done, and whether so. But if it's a really troublesome problem, patient may want to go for a surgery afterward. But we all treat the same because with the hope that fistula will close after treatment.
Okay, there is a question from Nazat that they follow the RTOG 0529 and they treat the two-phase treatment by volume, following the volume of RTOG 0529. So is it okay, or you have any suggestion? Currently, whatever few number of patients, they are following this.
Now, as I told that we all moved to IMRT, and when you treat with the two-phase conventional, so I think you did not treat the patient with more than 50.4 gray. So if your patient is early stage disease, that's probably is fine in terms of the dose, optimum dose of the treatment. But if someone with T3, T4 or node positive disease, then probably 50.4 gray is under treatment, under dose. And also in conventional, as we mentioned, that we are treating lots of bowel and unnecessary normal organs, unnecessary treatment to the normal organs, which is not needed. But But you are not the only one. I mean, there are a few other centers in the UK in some selective patients were treated with 3D conventional. And particularly there are some consultants also in my center where actually a person whom actually I learned most of the oncology, Dr. McDonald. So he sometimes treat some patients with a conventional, and it is mostly about it because he's an old school person, and he, for any new change, he probably doesn't want to accept much. But again, what I told that there is always a bit of fear about some patients during the IMRT, whether we are geographical missing of tumor. Because if it's a tiny lymph node somewhere which can be missed on the PET, which can be missed on the MRI, and we probably would not volume that in the IMRT planning. But if you do conventional, you will treat basically everything there. So the toxicity would be more though. So the answer to your question is IMRT is an answer, but if you already treated someone, it's already done, but you cannot go any higher than 50.4 gray with this treatment. In exceptional situations, some patients we are still treating in the UK, but which is very exceptional situation.
Thank you, Tariq. I think the message is very clear that with conventional, we cannot have the adequate dose. And now in the era of IMRT, if we should think of IMRT because we need to give the best to get the highest chance. But maybe we are quite fortunate. Majority of the tumor are not very big. So small tumor, we are getting a good result with the conventional treatment with the conventional dose. So now if you look at the ESMO guideline algorithm, and in the metastatic setup, from carboplatin to cetuximab and PD-L1 inhibitor, all these are there. So we know that till now, there is no good data for induction, but yes, we cannot ignore that we will not have a stage 4, even there is a 80% cure rate. There must be some stage 4 any part of our life. So Zahid, can you please help us? If we are facing a challenge like this with the stage 4 anal cancer, so how you suggest us to proceed? Zahid. Then unmute, Zahid.
Thank you very much. As you very rightly said at the beginning, that this is not my area of comfort. Last time I've treated an anal SCC, that will be more than 10 years ago, when I was just my senior registrar. But thankfully, very little has changed since then, isn't it? Lieutenant Colonel Nazat, Sultana, a really wonderful presentation. From my side, regarding metastatic setting, I do not treat the metastatic anal ACC. That goes to my clinical oncology colleagues. But my understanding is that the carbotaxol has proven to be the only so far beneficial treatment. So cisplatin 5-FU has been the mainstay of treatment for many, many years. And the carbotaxol has now pushed it to second line. Regarding the other options, whether you can use an anthracycline, whether irinotecan plus minus cetuximab, including immunotherapy, these are all phase 2 trials with a small number of patients. And that's what is making it difficult to use them as a standard treatment. But I'm sure, I mean, at the moment, the anal cancer is not treated as a site of cancer. It is more treated as a part of rare groups. There is a rare cancers consortium, which is trying to combine their experience internationally. So hopefully we will get a bigger trials. I'm sure Tariq will be able to elaborate more on that. But my practice or our practice is carbotaxol or cisplatin 5-FU. Regarding the immunotherapy, it's not funded within UK at the moment.
Thank you, Zahid. So message is very clear. If you are unfortunate to get an anal cancer and more unfortunate to get a metastatic one, so our first and last pick should be carbotaxol, because not to be tempted by the fancy words of targeted therapy, immunotherapy, because they have no robust data. it is not possible. We need to understand, because there are not thousands of patient fingertips numbers there to get metastatic, then to get a robust data is never a possibility. Rather, we extrapolate data from other sites. Again, it is not possible to extrapolate from rectal cancer because it is a two different world. So, I mean, to move from one protocol to another, especially in chemotherapy, is really not that easy. So,
can I add something here?
Yes, yes.
Yes, what Jahid says that for a long time, the cisplatin and 5FU was the first line treatment. And then Nazat presented about Interact2 trial, which was which showed that carbotaxol is superior in terms of the toxicities and also in terms of PFS and OFS. I think the PFS probably was not statistically significant, but overall survival is. Which is actually the other way around we see for the most of the patients, most of the cancer types, because basically it gives a message, because overall survival is statistically significant and it's actually bigger difference and a bigger benefit in the patients getting carbotaxol, and that gives us a message, because many of the patients here is actually getting multimodality of treatment. So some getting SABR, some getting operation, though there's evidence is less because it's a rare type of tumor. But also there's a paper published, which I cannot actually give the full detail now, because quite a while ago I actually read that for the anal cancer, the multimodality approach actually increase the survival. So if someone has got a tiny liver mets or tiny lung mets, or even is a pelvic recurrence, which is not operable, we can do SABR or any other treatment like ablation and different type of treatment, depends on where the tumor is. So only 10% patients actually get a metastasis at diagnosis. So so it's not a huge number, but yes, once they get that, nowadays, though is a phase 2 trial, Interact2 is not phase 3 yet. They probably will do phase 3 or never, because we don't, lots of trial always do not get to next phase. But I think that is a Maria Hawkins trial probably, and she was doing that, and I think there is a plan for phase 3. So after second line, if you look at NCCN, the American guideline, they mention many things. They mention even capecitabine, they mention FOLFOX. And generally what we do, if someone is progressed on platinum, like either cisplatin 5-FU or carbotaxol, then another platinum will not do any benefit. So we treated unconventionally some patient with a single agent capecitabine on progression, and there's not much benefit we actually was achieved. I treated 6 patients with immunotherapy, and to be honest, the response rate is, I couldn't find any good. But if you look at the immunotherapy trial, there's a 2 big immunotherapy, no, I would not say big, but the only 2 immunotherapy trial was done. One is a Keynote, another one is in the MD Anderson trial.
NCI 9673.
Probably, yeah, that's the one. And the response rate is 20 to 25%. So it's a very small number, very small, and the number of the patients are small. Also, response rate is not great, and we know that in the second line setting, always response rate is poorer. So so we need to look in the future what's happening. But nowadays, what we are doing in our center is a carbotaxol, and we talk about single agent capecitabine and ask for an unlicensed medication application, and also immunotherapy we treat with someone, but not with good success. So that's my comment.
Thank you, Tariq. Just one point came to my mind. I mean, it is not relevant to today's topics. Our next topics is surgical management of pancreatic periampullary carcinoma. Inshallah, next year we are going to manage it. But I want to ask both of you one question now. Almost every day we all are facing that, say it's a lung cancer, whatever it is, we are having a uptake in the vertebra or somewhere else, and they are writing they're suspicious of bone metastasis. There is no local tenderness. I mean, we cannot do a bone biopsy, unfortunately, in our country very routinely I mean, what is your practice? I mean, how you resolve? Are you doing always a biopsy, or you are doing MRI, or you are doing a clinical judgment? Because moving, say, lung cancer, stage 3 and 1 vertebra suspicion, making stage 4, moving from CTRT to palliative. So how to resolve? I mean, how you resolve in your situation? I want to hear from both of you.
Tariq, do you want to go ahead?
I don't mind. I mean, it depends on actually the whole picture. But if it is just a one single, and if it's suspicious, not fully confirmed, then sometimes we go for benefit of doubt. But if we think that no, we need to get a biopsy, we do a biopsy. But biopsy in the bone is difficult, and mostly we go for radiological assessment. And our radiologists, sometimes they ask for bone scan, PET scan, MRI, even musculoskeletal MRI, all those things. And we try to get an answer without biopsy from all these modes of investigation. But sometimes, even if we fail, we sometimes give benefit of doubt to the patient, and with close observation. Because we know that now lots of local treatment has come, because if it's a solitary treatment, there's a lot of local treatment options will be in the future, like Sabre is opening and all those stuff. So yeah, it depends on very much like an individual patient situation, to be honest. But bone biopsy, we try to avoid. Go ahead.
I fully agree. I'm assuming the common vegetable it is in the context of a radically treatable cancer, but you've got something out in the bone. And as Tariq Bhai said, that if you could consider any other radiological modality, that's great. But otherwise, neither we go for like an aggressive bone biopsy. Let's go back to something more common that we use, like in rectal cancer. If you have a radically treatable cancer, then you've got few lung nodules on a CT scan, and those are below the threshold of the PET, like less than 10 millimeter size. They're not going to light up on the PET scan. Then we still treat them with radical intent, don't we? So I think that's the common sense approach we should take, that if you have got a radically treatable cancer, you've got something funny in the bone, and you cannot characterize any further, I think there is no reason not to treat this patient with radical intent. Let's not forget what Tariq Bhai said, that only 10% patients present with metastatic disease. And even at relapse, only 10 to 20% patient presents with distant metastatic disease. So overall, this is a local regional disease, and local regional approach should remain the mainstay.
Thank you, Zahid. Ami kothata intentionally এনেছি. Yesterday, I had 2 cases. One was a base of the tongue surgery done. Routine, I was doing the metastatic workup, and the CT scan chest shave, 7 millimeter single nodule, bracket, exclude metastasis. And I'm sure many of will not read, they will see metastasis and they will jump in, there is a metastatic. So we should not jump into this, number one. Another case, it was a lung cancer patient. There was 3 points in vertebra, suspected of metastasis, 1 in the rib. And when I look at the local examination, there was no local tenderness. And I asked for MRI because, as you said, I want to do at least another more imaging to confirm, because bone scan, we know it is not a conclusive thing. So these 2 messages I wanted to share with our colleagues, that one modality like bone scan, if say there is a, and you see, they never write conclusive, they say it is suggestive, please correlate clinically and radiologically. They write some conventional word to save their own skin. So for our country colleagues, that if you find something like this, please cross-check with other modalities, do the local examination, and then conclude. Otherwise, don't jump and conclude that this is a metastatic. So with these few words, I want to thank our academic partner, Acuvida, who has been supporting us. And next week, we will have a surgical colleague talking on the role of surgery in pancreatic and periampullary carcinoma. Both of you are invited, Tariq and Zahid. I mean, even you are not the part, but it will be interesting to listen to the surgeons, what they do, what magic they do with the pancreatic and periampullary, because before and after we have something to do in periampullary and pancreatic cancer. So with these few words, I think today already we have finished, took 20 minutes more time. Intentionally, I took it because anal cancer is not a very common, but it is a very good curable patient cancer. If you can really treat properly, the success rate is near about 80%. So we should know it properly and we should not miss the chance, because first chance is the best chance. And hopefully, inshallah, we will have good. So Zahid, we have a session on colorectal cancer next weekend. Please attend it. Yes, inshallah, share the flyer with all of us. We will try to, last time we attended one, Parvinapa and Shadat Bhai was the faculty. It was a very interesting. Tariq was there, you were there. I enjoyed it. Hopefully, inshallah, next week we will try to join.
Thank you very much.
Thanks for joining both Tariq and Zahid and all our local participants. And again, congratulations to Nazat for the brilliant presentation. And thanks to everybody for joining, inviting you all for next Sunday to attend the session on pancreatic and periapulmonary carcinoma surgical lecture. And till then, stay safe. The rate is going very high in Bangladesh. I mean, the situation is not very good, but we cannot stop our work because we are the frontliners. So may Allah save us all and see you next week. Thank you. Thank you very much.
Thank you very much.
Sir, I said. Sir,
So
thank you, sir. So thank you, everybody. Goodbye. See you next week.